All right. So we're sort of leaving now the conversation of MI and sort of what that means pathophysiologically. But before we do that, I forgot to mention one thing before we went to break. You know, I've talked so much about these STEMIs that occur that you actually see the changes on an EKG. And knowing that it's an MI because of that ST segment elevation. It is possible, and I just want to mention this, especially for people who are on cardiac units or on step-down units here with clinical or even next semester. It is possible to have a non-STEMI MI, meaning that you don't actually see an ST segment elevation on the EKG, but there still has been an infarction, there still has been injury to those cells, and the reason that you would know that is because you see changes in the blood work. So like you would see an elevated troponin, but you don't actually see the actual elevation on the EKG. So that probably means that that person has had a heart attack if you see elevated troponin. It just may not be as severe in terms of the myocardial damage done to actually see an ST segment elevation. So I just wanted to be clear, but so if you hear those terms, that it is possible to have a non-STEMI, but it still is a heart attack, but it's more due to sort of things that you see in the blood like troponin and other isoenzymes like CKMB and things like that. So I just wanted to mention that in case you ever hear about that clinically. We just didn't necessarily talk about it today. So, all right, so now let's move off of the sort of MI talk, and we're going to talk about some of the other layers of the heart and disorders of some of those other layers. Specifically, the pericardium, which we're going to have like 2 slides on, and then we're going to spend the rest of the morning here talking about disorders of the myocardium and looking at like cardiomyopathies and heart failure, okay? And we'll go from there. So, disorder of the pericardium. The one disorder that we're going to talk about today regarding the pericardium is acute pericarditis. This is actually inflammation of the pericardium. And remember when we talked about the pericardium, it is that most outer sort of protective lining, dual membrane lining of the heart. It can either be for idiopathic reasons, meaning we don't really know why it gets inflamed, or sometimes it can be because of some sort of infection, a viral infection. So sometimes you'll see this be sort of the result of influenza. Sometimes you'll see it with hepatitis. Sometimes you'll see it with those sort of what are now sort of rare contagious diseases like measles, mumps, rubella, things like that. We used to see that. I shouldn't say we. I did not see that. Historically, one might have seen some pericarditis with a lot of these contagious sort of pediatric infections and things like that. We okay? Got a question? Okay. So really what happens here is that the pericardial membrane, the bilayer membrane, becomes inflamed and sort of roughened. It actually kind of looks kind of shaggy, kind of sandpapery. And you can imagine then that symptoms, depending on how bad that inflammation of the pericardium is, can sort of vary. So oftentimes, because of the inflammation, you'll see several days of fever. You'll see this complaint of this sudden onset of chest pain. This chest pain will usually worsen with breathing, so it'll worsen with respirations, or when lying down flat, or sort of in a recumbent position. What I want to be clear about with chest pain because of like acute pericarditis is that chest pain with acute pericarditis is what we would refer to as reproducible. And what I mean by reproducible is that you can produce the pain. If you ask the patient to take a deep breath, or you ask the patient to lie down, it could increase their chest pain. That's helpful when trying to sort of diagnose between what's the cause of this chest pain. So let me ask you this. Someone who's having chest pain because of sort of acute coronary syndrome, like we just got done talking about, can you reproduce that pain? Does their pain get worse when you press on their chest or when they take a deep breath or when you have them lie down? No, it doesn't change the pain. And that's something sort of key to know. Wink, wink, right? That coronary artery reasons for why someone's having chest pain is not reproducible. Other things like acute pericarditis is reproducible. You can make the pain worse. And that can help you sort of be a diagnostic tool in terms of why someone might be having chest pain. You also may hear when auscultating the heart sounds, something called a friction rub. Does anyone know what that is, or did you learn about that in Batty, or tell me a little bit about what a friction rub is? It's actually kind of a scratchy, grating sound, like almost like sandpaper rubbing up against each other during auscultation of the heart sounds. What might cause that? Why would you actually hear a friction rub when listening over someone's heart with pericarditis? It's because of, for one, it's because of the actual membranes being sort of rough and shaggy that are sort of, there's causing friction when those two layers of the pericardial sac rub over each other. It also may be because of, there might be increased fluid or maybe decreased fluid in that pericardial sac, and we talked about how important just the right amount of fluid in that pericardial sac, excuse me, is so imperative. So that's why you may hear a friction rub when auscultating. And then the other thing you may hear because of increased fluid in that pericardial sac is what we call muffled heart sounds. Again, when auscultating with your stethoscope over the heart with someone with pericarditis, the heart might sound muffled. Like it might be hard to hear the S1 and S2 because there's excess fluid in that pericardial sac, and actually it sounds like you're listening to it through water, right? It has more of a muffled tone to those S1 and S2 sounds. Again, because of the inflammation and the excess fluid in that pericardial sac. And because of that, you're seeing, really basically you're seeing major sort of inflammatory type symptoms around the heart. So not good, right? Not a good thing to have going on around your heart. What might be the treatment? I didn't even put it up here. But what may be the treatment, now that you sort of understand the pathophysiology of it, for someone hospitalized with acute pericarditis? What do you think? Well, if it's due to some sort of infection, you're obviously treating the underlying cause, right? You're treating the, whatever the infection, the viral infection, whatever it may be, that actually caused the inflammation of the pericardium in the first place. Relieve symptoms, so if they're having pain, you give them pain medicine. You'd obviously be doing a lot of sort of medications in terms of anti-inflammatory, because obviously there's an inflammatory cause to this, so a lot of anti-inflammatory, maybe steroid type medications would be the key treatments for acute pericarditis. Quickly, kind of changing gears here, but kind of on the same page, another disorder of the pericardium is a pericardial effusion. This is where you start to have a lot of fluid building up in that pericardial sac. It can either be serous fluid, so it can be just clear fluid, and you can also have blood in the pericardial space. I've oftentimes in trauma seen blood pericardial effusions because of like a gunshot wound to the chest or something where they're dumping in a lot of blood into that pericardial sac around the heart. Reasons for why there might be more sort of interstitial, sort of serous fluid in the pericardial sac would be because of like congestive heart failure, where they're just not able to push, the heart is not strong enough to push a lot of that excess fluid up and out to the body. So you know how you get like edema in the legs or in other tissues in the body? You can also kind of start to have fluid building up in that pericardial sac around the heart as well, very much similar to edema in the peripheral areas like the legs and arms and things like that. So that's what a pericardial effusion is. It's a buildup of fluid in that pericardial sac. Remember I said normal amount of fluid in there is about 10 to 30 cc's. So we're talking about fluid accumulation in excess of like 30 cc's in that pericardial lining around the heart. If the pressure in that sac gets so great, it actually starts to exert a lot of force and pressure down on the heart. That is called a cardiac tamponade, which is the term that I have up there on the screen for you. And that's when you actually start to have so much pressure building up on the heart and on the heart muscle itself that it actually starts to dysfunction. It starts to not be able to work because you're actually putting like a rubber band or a tourniquet around the heart, and it just is not going to work. I mean, it's under too much pressure to have that normal sort of expansion and relaxation of those ventricles that we talked about, of that Frank Starling law of the heart that we talked about last week in terms of stretch and elasticity of those ventricles. You just have too much pressure and they can't do that. So to be clear, a pericardial effusion can cause a tamponade. And then last but not least, you can also have constrictive pericarditis where you, because of that that acute pericarditis, it can sort of turn into more of a chronic situation where you get like scarring of the pericardial layer with calcifications and sort of fibrotic kind of tissue forming, which obviously, as you can imagine, kind of also acts as sort of a restriction or a constriction, shall I say, on the heart itself, and it's not able to pump, and you have the normal contractility. And so you start to see it constricting, the pericarditis itself sort of constricting on the elasticity and the ability of that heart to contract. Yeah, question, sorry. I'm losing my peripheral vision. Yes? Yeah. Yes. Where they start to get narrow and right, exactly. Yes, exactly. And you won't necessarily have to know that for purposes of this course, but yes, exactly, that's what you start to see. Okay, I'm not going to spend a lot of time on disorders of the pericardium, but I just wanted to mention some of those things to you today. Again, not saying that you won't necessarily need to know what I have up here on the screen or that it's not important, but we're not going to spend as much time on this content today. Here's a really good picture, though, of pericarditis. You can see here, note the shaggy sort of coat of fibers on the outside external aspect layer of the heart. Again, this shaggy sort of rough look to the pericardium is due to inflammation. So you actually have inflammation of the pericardium. Yeah?
So when this is treated, will the shaggy appearance kind of go?
Yes. Yes, especially with acute pericarditis, this is totally treatable. And you can go back to normal. Yep. Now, maybe not so much with the constricted pericarditis where you start to see the actual fibrotic changes occurring like scar tissue to the heart, but with acute, absolutely. Good question. Okay. Disorders of the myocardium. Also, super pertinent to our practice. Going to see issues like cardiomyopathies and heart failure all the time. So let's make sure that you understand them well. Okay, so to start off, why are we so concerned about disorders of the myocardium? Hopefully this should be glaringly apparent to you by now. I think I've beat the dead horse. Why are we so concerned about dysfunction of the myocardium? All together now. It's the pump. I mean, it is the muscle. It's the bulging bicep of the heart, right? If the heart has some issue with some sort of disorder with the myocardium, we're going to see ejection of blood falling off, right? We're going to see there's going to be some type of ejection problem. There's going to be some type of problem with the pump of not getting that blood specifically out of the left ventricle up into the aorta and out to the whole body and out to the whole system. So we are extremely concerned with disorders of the myocardium. The term we use quite commonly with disorders of the myocardium are cardiomyopathies. Hopefully that should sort of be intuitive. But really these cardiomyopathies are sort of a diverse group of diseases that primarily affect the myocardium itself. Usually cardiomyopathies are a result of either ischemic heart disease, so all those reasons that we talked about earlier this morning of lack of blood flow to the myocardium would obviously then cause problems with that myocardium being able to contract. But also, what may also be a reason or sort of a causative factor for cardiomyopathies is hypertension. Why would hypertension, systemic, vascular hypertension, why would hypertension also pathophysiologically may lead? Yeah. Right, okay. So we talked about the whole issue of preload and afterload last Monday, right? And we talked about how preload is the amount of blood sort of filling up. It's the volume of blood filling up that ventricle and filling it out so that it can come back and contract really hard. So that's preload. What's afterload? What's the definition of afterload? Yeah, the pressure that the left ventricle has to sort of pump against to get that blood up and out of the heart and to the body. And we said that a really good example of afterload, of that pressure that the left ventricle has to pump against, is our blood pressure, right? So if someone has a normal blood pressure of 120/80, that left ventricle can push against that quite easily, right? But what if someone has a super high blood pressure? Like, I told you about, I've had patients come into the ER with like 220/100 types of blood pressure. How's the left ventricle going to do against that? Not good. And when you increase the work that you ask the left ventricle to do, it's going to hypertrophy. Just like how our bicep gets bigger when you increase the amount of work that you ask our bicep to do with lifting weights, right? You increase the resistance, you increase the pressure, the muscle's going to get bigger. No matter if it's your bicep or your myocardium, right? So you can have major issues with the health of the myocardium with hypertension because of how much pressure that left ventricle has to pump against. A hypertrophied bicep looks good. A hypertrophied myocardium is never a good thing. It doesn't function the same. It doesn't function as well. If you have an enlarged ventricle, it does not work the same. Okay? So let's talk about the different types of cardiomyopathies. And I'm going to sort of list them here, and then I'm going to go to the next slide where I've got pictures, and it makes it a little bit easier to sort of visualize these different types. But you've got dilated cardiomyopathy, you've got hypertrophic cardiomyopathy, which is what I just sort of explained with hypertension issues, and then you've got restrictive cardiomyopathy. So let's go to this next picture and talk about each one of these more specifically. So cardiomyopathy, basically, you'll hear them refer to cardiomyopathy and heart failure sort of interchangeably, but in my mind, cardiomyopathy sort of leads to heart failure, and I'll sort of show you why. So here's a normal heart, right? Here's the left atrium, the left ventricle, the aorta that shoots out, right? Okay, look at compare the size, note the sort of morphology of the size of these chambers, okay? Here's normal. Now in B, this is dilated cardiomyopathy. So first of all, just so you know, dilated cardiomyopathy is usually the result of ischemic heart disease. So these patients that we were talking about earlier this morning with coronary artery disease, lack of blood flow to the myocardium, you're going to see quite commonly dilated cardiomyopathy. You can also see this kind of happening with valve disease because you've got that leaky valve that's letting in either too much blood or not enough blood into these chambers. You'll quite often see valve disease leading to dilated cardiomyopathy as well. But either way, if you have a dilated left ventricle, what do you think, again, close your eyes, see it like a movie, remember that whole issue of Frank Starling Law of the Heart. What do you think is going to happen to the ejection of blood from a dilated, sort of overstretched left ventricle? What do you think? Decrease. You're going to have what we call systolic dysfunction. So remember, systole is the contraction, right? You're going to have contraction dysfunction, systolic dysfunction, leading to what? If the left ventricle can't pump the blood out, what's going to happen? Blood's going to sit there, right? Blood's going to sit there in that left ventricle with this weakened muscle that can't pump it out. And you get sort of over volume in the left ventricle, which also contributes to that blowout look, that dilated left ventricle look. So you get an increase in intracardiac volume because the heart just can't pump it out. You'll see ventricular dilation also because of that. And you'll see what we call systolic heart failure. So you've got heart failure because of a problem in the systolic phase of that cardiac cycle. What's the poor little brain and the poor little kidneys and the poor little liver thinking in this situation? Where's the blood, right? It's all sitting in the left ventricle, overextending and dilating and stretching out that left ventricle, and it's not getting pumped out, and the other organs in the body are getting starved of oxygen-rich blood because it's all sitting in the left ventricle. That's dilated cardiomyopathy. Does that make sense? Okay. How about C, hypertrophic cardiomyopathy? Well, I just told you that that's probably due to systemic hypertension, where there's so much pressure in terms of blood pressure in the aorta that the left ventricle has such a hard time pumping that blood up and out that it just starts to get big. It starts to get hypertrophied because of that increased resistance that it's constantly pushing against to get blood out. So you see thickening of the wall, usually due to resistance to ventricular ejection. And you're just building up that muscle like you build up a bicep. But again, you're going to start to see heart failure with this because the left ventricle that's big and hypertrophied just can't contract normally. And then D, restrictive cardiomyopathy, characterized by restrictive filling and an increased diastolic pressure. So again, this could be because of like pericarditis or a tamponade, where there's so much pressure bearing down on that heart and on those chambers that there's restriction to filling. Now, why would restriction to left ventricular filling be a problem? Why would the left ventricle not be able to contract as well if there's decreased filling going on? Yes. If you have less in, you have less to pump out. And if you've got less in, you've got less of that stretch of that Frank Starling law to allow for good contractility to snap back and pump that blood out. Good. So restrictive cardiomyopathy, if you're restricting how much blood gets into the left ventricle, you're clearly restricting how much blood that left ventricle can pump out. So in this case, we talked about this whole conversation of preload and afterload, and how hypertrophic cardiomyopathy can be because of increased afterload. But restrictive cardiomyopathy is actually due to a decreased preload, right? A decreased amount of volume getting into that left ventricle because of its restriction. Any questions about those different types of cardiomyopathy? Ultimately, the pathway after you understand the reason, the pathway after that is the same. Either way, there's an issue with the left ventricle pumping blood out. And what do you start to see? End organ, and by end organ, I mean all the other organs in the body at the end of the, of the artery sort of flow, starting to decompensate as well, because they're getting lack of blood flow, because the left ventricle is not pumping out to them. All right, which, as I mentioned, leads to generalized heart failure. So all of these reasons leads to a failure of the pump failure, heart failure, right? So a general term used to describe a lot of different types of cardiac dysfunction, like we just talked about, that result in inadequate perfusion of the tissues of the rest of the body. So again, in my mind, I think of cardiomyopathy as leading to heart failure. Oftentimes you'll hear them sort of used interchangeably, but in my mind, one is sort of the subset of the other, or a sort of precursor to the other. Okay. And again, just how we talked about on last week on Monday, how we sort of have two different hearts, right? We have the left side of the heart and we have the right side of the heart. You can sort of think about left-sided heart failure or right-sided heart failure as well, because again, they are two different pumps that pump to different parts of the body, right? The right heart, the right side of the heart pumping to the lungs, and the left side of the heart, or the left heart, pumping to the body. So you can't have failure of just one side. But ultimately, as I mentioned last week, the input of one is the output of the other and vice versa. So ultimately, if you've got right-sided heart failure, what's eventually going to happen? You're going to get left-sided heart failure, or vice versa. But it's possible at first to just have one side of the heart failing. It's possible. Ultimately, they're both going to poop out because they're connected to each other, but initially you can get one. So let's talk a little bit about true left-sided heart failure. So let's say for now, the right side of the heart is fine, but we've got some left ventricular failure, right? So we've got left-sided heart failure. It could be either because there's an issue with the systolic phase of the cardiac cycle or the diastolic phase, and you can sort of see here sort of the reasons for why, but we basically have talked about that already. So, why there might be a problem with the filling or the pumping of the left side of the heart. Any questions about what you're seeing up here on the screen? I'm not going to necessarily read those to you because we just talked a lot about, why either filling or pumping might be a problem. Either way, it's going to cause some sort of failure on that left side. What I really want to spend time talking to you about is what that looks like, right? We've talked sort of ad nauseum about the patho of why that might occur in the left ventricle. But what does our patient look like now when they've got left ventricular failure? So don't look at the screen for a second And just think, regarding the flow of blood and all this conversation that we've had over the last couple of lectures together, if your left heart is pumping, or not pumping properly, what kind of manifestations might we see? We've already said that obviously the tissues, the outside sort of distal tissues aren't getting enough blood because the left ventricle is not pumping to them. But what else might you see? If you've got this failure of this pump, blood's not getting out to the body, so where is that blood? It's either sitting in the left ventricle, sort of with that dilated cardiomyopathy, and then it's like a traffic jam, right? Everything just kind of starts backing up and backing up and backing up along that flow of blood flow that we talked about on last Monday. So what else might you see? Where's the blood going to, if the blood's getting backed up in the left ventricle, where's it going to back up to after that? The left atrium, and then obviously the lungs. So if you've got all this excess fluid and excess blood in the lungs, what kind of symptoms might you see at the bedside for a patient with left ventricular failure? Yeah. Yes. So they're going to be short of breath because you've got all this fluid just sitting in their lungs. They might cough up, not so much frank, bright red blood, but what is very classic in left ventricular heart failure or left-sided heart failure is this pink-tinged frothy cough. And the reason for that is you've got this blood sitting in their sort of tissues in their lungs, and the air is sort of moving through it. So it kind of gets frothed up, like the way a smoothie would, or you understand what I'm saying? When you insert air into liquid, what happens? It gets frothy, right? And so what they cough up is this sort of blood-tinged frothy sputum because of all this fluid sitting in the lungs that the air is trying to move through, and they cough up this pink-tinged frothy sputum. Classic sort of manifestation of left-sided heart failure. So results, as you see here on the screen, in pulmonary vascular congestion. So all the fluid gets backed up in the vessels within the lungs. And you basically have, alongside of it getting backed up in the heart, you also have inadequate perfusion of the systemic circulation, which what we talked about. So the two sort of categories of symptoms that you see are either because of excess fluid in the lungs, like shortness of breath, crackles when you listen, oscillate their lungs because of the increased fluid in their lungs, or you see things like change in mental status because they've got lack of blood flow to the head, or the kidneys start shutting down because there's lack of blood flow to the kidneys, right? So the two categories of symptoms that you see is either because of not enough blood out to the system and too much blood backing up into the lungs. Does that make sense? Yes? Okay. So like I said, you may see what we call pulmonary edema. So basically edema in the lung tissues. So how's their O2 sac going to look when you hook them up to the monitor? Crappy. They might look a little bluish. They might be a little cyanotic because you're just not getting enough oxygen through all that fluid and blood and excess fluid that's sitting in the lungs. Their O2 sat's going to look bad. Any questions about any of the other sort of things that you might see upon physical examination? So cyanosis, crackles when you listen to their lungs. You might see some pleural effusions. So you can see some fluid building up in that, just how there's a pericardial sac around the heart. There's also a pleural sac around the lungs. So you can see fluid sort of building up in that little cavity on the outside of the lungs. Hypotension or hypertension, depending on how much blood is actually getting pumped out of the blood. In my mind, or pumped out of the heart. In my mind, you're probably going to see hypotension in these patients because they're just not getting enough blood out into that systemic circulation. And S3 gallop is just a specific type of murmur that you hear when someone's in sort of fluid overload. And then obviously these people are probably going to have some sort of underlying coronary artery disease or hypertension or something like that. Does that make sense? So the manifestations of left-sided heart failure make sense. Yeah?
Why would it be more hypotension than hypertension?
Because they don't have fluid in their systemic circulation. So like think about what they're, and again, it may depend on patient to patient. That's why I wrote either one or the other. But think about it. If all the blood is sitting in their heart and or lungs, there's really not that much pressure in their systemic circulation because all the blood is in their pulmonary system. So sometimes we refer to it as pulmonary hypertension, but the systemic blood pressure probably is not very good. Does that make sense? Because it's all in the pulmonary system. It's all in the pulmonary blood flow. Good question. Make sure that makes sense to you. Okay. Then, so that's true left-sided heart failure. What about true right-sided heart failure? Okay, most commonly caused by some sort of restrictive pulmonary disease. So if there's something going on in the lungs that's increasing pressure and increasing resistance to that right ventricle pumping blood out into the lungs, what's going to happen? What's going to happen to that blood flow if it's restricted from getting to the lungs? Where's it going to back up? In the right ventricle, then the right atrium, and then where's blood going to back up from the right atrium? In the systemic circulation, right? Think about that flow of blood that we drew on the board the other day. So now, for pure right-sided heart failure, what kind of symptoms are you looking at in your patients with pure right-sided heart failure? Systemic edema, right? Big swollen ankles, right? Big swollen legs. A lot of it, I mean, I'm talking about like, pitting edema. You press in their lower legs and, your finger sinks in like 2 inches, right? Super profound systemic peripheral edema. So generalized systemic edema. Now, as I mentioned, the input of one side is the output of the other and vice versa. So if you ultimately have one side fail, you're ultimately going to get the other side to fail as well, right? So left ventricle fails, which then means that it backs up into the left atrium, which means that it backs up into the lungs, which means that it backs up into the right ventricle, the right atrium, and the system. So eventually, the whole thing's going to be out of whack. If someone's got true profound heart failure, you're going to see both symptoms of right-sided and left-sided heart failure. Does that make sense? How do we fix this? How do we fix heart failure? Say that again? Diuretics. Why? Yeah. Are we going to fix the heart probably? Are we going to fix that myocardium that's been damaged and dead and overstretched and whatever? Probably not. So we fix it by getting rid of that excess fluid. We're not going to fix the muscle, so let's take out some of the excess fluid that muscle has to try to pump. And we will do that through diuretics. What's a big one that a lot of people with heart failure, a lot of patients with heart failure, what's the big diuretic that most of them are on? Lasix. Good. Very good. Okay. So, treatment for heart failure. Diuretics. There also is that other category of drugs that we sort of touched on last week, the positive inotropes. Remember, we have positive inotropes that increase contractility of the heart, and we've got negative inotropes that decrease contractility of the heart. Oftentimes, people with heart failure will be on some type of positive inotrope to try to increase whatever contractility is left in that muscle. Let's try to increase it, right? So they'll oftentimes be diagnosed with, prescribed positive inotropes as well. In fact, I had a lady one time in the ER that had such profound heart failure that she was, even at home, continuously hooked up to a continuous positive inotrope IV drip. I'd never seen this before. She comes in with like a home pump it was a drug called milrinone, who she lived with this IV drip of this positive inotrope because of her profound heart failure. It's like, okay, this is end-stage heart failure if I've ever seen it. You're at home with an IV because of your poor pump. So treatment for heart failure are usually those two things. Diuretics usually the most common, the most normally seen and normally that you as a practitioner will come into contact with. Yeah. Digoxin isn't necessarily a positive inotrope. It's not in that same family of like the milrinone that I just talked about, but oftentimes it can help with contractility, and it is quite prescribed most commonly for people with heart failure as well. But those are the two that we're going to sort of focus on for this course for patho. All right. Any questions? Any questions about anything that we've talked about today? Can you see how what we discussed last week really laid a good foundation for what you truly have to understand, pathophysiologically speaking, in terms of someone with coronary artery disease or someone with heart failure? Hope that makes sense to you. Okay. All right. Well, we will stop there, and we will finish up our last lecture next week with the conversation of shock. Shock is not a cardiovascular disorder in the way that we talked about, like problems with the pump today, but it certainly is an issue of lack of blood flow to tissues in the body, and so it kind of fits well in this whole cardiovascular sort of tissue perfusion conversation. So we will talk a little bit about that next week, finish up with that, and then we'll finish the rest of our lecture next week in discussing pediatric alterations in heart function and cardiovascular function. So, all right. Thanks, guys. And I will tell you that the simulation on Thursday will be with the content that we talked about today, so you will be well prepared.